1, 2, 3, 1, 2, 3. Testing, testing. Yeah, I know I'm admitting one person, but I was going to ask them if they could hear it. See if you can hear me. Testing, testing, 1, 2, 3. Yeah, okay.
Okay, so I'll have people hand it to each other. What? Okay, good. It's on Zoom as well. I know. You want me to call it? Oh, that's not good.
Hello, everybody on Zoom. You probably didn't hear me before. We'll start in about 2 minutes. Hopefully the computer. Ed, do you have any of the Zoom members on camera on? Okay. If you can hear me, raise your hand. Great. Fantastic. I'm gonna have my back to you, so just a minute. I'm gonna try to stay in this. And I just, so we're gonna be moving, oh, this microphone, we're gonna be to each other and we're just gonna keep pushing really great to you want to push it to them. We're missing one. Oh, that's you. Okay. 1 o'clock. Okay. Hi, welcome. Welcome to Artworks. If you've not been in this building before, I'm going to give you the spiel. If you've been in here before, you've heard it before. We are a nonprofit organization. We rely solely on donations. We have been here for 11 years, possibly 12 years. I'm currently the chair. We're a working board, and we have 28 studios, 2 the gift shop and the gallery, and all the artists who work in this building also get creator space next door for free, which is awesome. Ways that you can help us shop, share us on social media, follow us on social media, come to the shows. We're open every second Friday for shows like this. Each show lasts about 2 months. This is our long COVID show. The artists in the show have made work and have told their stories. Every piece of artwork has a story next to it. And it's very eye-opening to see how it's changed their careers, it's changed their lives. And so today we're going to talk about the medical portion of this. This show was brought to us by Sally Harshorn. This was her idea. She's going to talk a little bit about herself. And I want to say thank you to Elizabeth Soriani, who is our gallery chair, who is our curator for the show. And sorry, she couldn't be here today, but she's on Zoom. Hi, Elizabeth. And that is all. Sally, thank you for being here. Appreciate it.
Thank you. Hi, thank you everybody for attending, especially to the board who are not paid, coming in on a nice Sunday and offering their expertise. Just my story real briefly. My name is Sally Hartshorn. I'm a retired nurse. I got COVID in February 2023, developed long COVID. It was not pleasant. I went from being super active, hiking, skiing, taking music lessons, art lessons, language lessons. And I had to give it all up. I could barely help around the house. I did some research and I found these studies out of Israel about hyperbaric oxygen therapy. I got treatment at the Rocky Mountain Hyperbaric Oxygen Institute. It was 2 months of treatment and it worked. And when I got better, I realized, I met so many people on the Facebook pages who had long COVID, whose stories were worse than mine. And so many of them that I decided I wanted to bring a voice to long COVID. I wanted to have the people who have long COVID a chance to tell their story, which is why it's here for the artwork, why they did the artwork. But I also wanted to have the medical community talk to each other, talk to the public, and have just a mutual exchange about what's going on with long COVID, what they're doing to help. And I've learned so much since I started doing this. Just real quickly, there are about 18 million people in the United States who have been affected by long COVID, and over 755,000 people in Colorado. That's a lot. So there's over 200 symptoms, no cure, and there's no specific diagnosis. So it's difficult. I want to thank Artworks. They've done a huge amount of work getting this together, Jenny and Elizabeth. To my delight, the Lieutenant Governor's office has just stepped in and really encouraged me to get a little more publicity around this. The panel and all my artist friends. And quickly, I did 2 retreats with a woman who's a psychologist and she works on somatic healing and nature. It really helped me when I was sick with long COVID. It didn't cure me, but it helped me emotionally deal. You get kind of post-traumatic stress syndromes, really helped with that. And it did help tamper a lot of my symptoms. She and another coworker are coming up to Colorado in sometime this fall and doing a 1-day retreat specifically for people with long COVID. We don't have the details yet, but there's a write-up on the table over there. If anybody's interested, just put your name and contact information. We will not send you any information except about the retreat. We don't do spam or anything like that. So I think I've said everything I need to say. Yes. So okay, we have to keep the microphone right close to our mouth. So what happens now is I'm just going to go through and tell you who's on the panel, but they know more about what they're doing than I do. So I will let them speak for themselves. And first is Dr. Julie Stapleton. She oversaw my hyperbaric oxygen therapy. When I met with her, I was totally impressed with her thoroughness and intelligence. Just interviewing me as a patient and being a nurse. So I asked her to come speak about that. Sitting next to her is Julie Pearson. She is a speech therapist, a cognitive therapist who works with people with long COVID. And next to her is Mirwais Bahish with he's the Colorado Senior Policy Advisor on long COVID and post-viral illness since January 2023. And they've been doing I had no idea how much they're doing at the state to bring more awareness and more communications about long COVID. And then we have Dr. Matthew Light and Michaela Martinez, and they founded the long COVID information discussion support group that's held monthly via Zoom and in person at UC Health Medical Center of the Rockies. And they have almost 400 participants from 7 different states going. And they have tons of information in those meetings. So you can go in person or via Zoom, and they will probably give you information on how to do that. And I'm going to pass the mic and we can just go down the table. Just remember.
Hi, again, my name is Julie Stapleton. I am a physiatrist, which is a doctor of physical medicine and rehab. I had a long career mainly in brain injury rehab or neurotrauma. And about 18 years ago, I got involved in hyperbaric medicine to treat that patient population with some really fabulous outcomes. And as I've age appropriately came closer and closer to retirement, I've been closing down my practice, but continuing in the hyperbaric world because I'm so overwhelmed by the benefit for a wide range of conditions. And what hyperbaric oxygen therapy is, it's breathing high dose oxygen under pressure in a pressurized chamber. And what that does is the high dose oxygen gets forced by the compression of air to dissolve into your body fluids. It's kind of the opposite of what happens when they make soda pop. When you open a can of soda pop, all the bubbles come fizzling out because you've decompressed it. They had created that carbon dioxide to dissolve into the fluid under pressure, and then you open the can and it comes out. Well, we're doing that same thing with high dose oxygen. We're getting that oxygen to dissolve into all your body fluids such that you'll have 20 times more oxygen available to every cell in the body. And what high dose oxygen under pressure is, it's a fabulous wound healer. It's a fabulous anti-inflammatory. And we have demonstrated through evidence-based science that it regulates the immune system. If your immune system is weak, if you're immunocompromised, it boosts it. If your immune system is hyperactive, you got an autoimmune disease, it can quiet that. The other thing it does is it triggers neuroplasticity, which is the nervous system's ability to heal itself. There have been studies done on hyperbaric medicine in long COVID, and it was one of the first couple studies that started showing an improvement in complaints of fatigue, improvement in sleep, improvement in cognitive function, reduction in pain, and it improved mood and depression and anxiety. A year later, they went back and looked at a small number, not everybody in the original study, but about 31 of the original study participants were looked at again and still had higher scores in quality of life, pain, cognitive function, fatigue, sleep, etc. It does not work for everybody. It does not work in every situation. I can't promise anybody anything. The biggest downside to hyperbaric medicine is it's most often not covered by insurance. It's highly intensive in terms of time and cost, resource commitment, and that is the biggest downside because it's otherwise safe and can be effective in several conditions in most but not all situations.
Thanks. And I'm Julie Pearson. I'm a speech language cognitive therapist. I work for University of Colorado Health, and I'm part of the long COVID team with some of the Denver Metro providers like Dr. Sarah Jolly and Liz Nuchin, and work physically out of the Boulder Clinic, and also do integrative coaching, private practice, and have been trained in a lot of mind, body, and somatic work as well. Been working with long COVID the last 5+ years. And initially as a speech therapist, we were preparing for a lot of respiratory compromise, and that was the main lens. And as you all know, and we all know, there's several different elements medically that we're finding out some of the why behind long COVID from a standpoint of the neuroinflammatory process, the immune process, an endothelial dysfunction where the body can't pump the blood in the same way and doesn't have as much nitric oxide, from a standpoint of an upregulated nervous system. I walk around and see some of this art, and it's like this constant state of threat. We know in other realms, there's a somatopsychic impact. I can think stressful thoughts, my heart rate can go up. I can think stressful thoughts, I can get a gut ulcer. In long COVID, as with a lot of other Lyme disease and a lot of other chronic disease, it's a somatopsychic threat where the body's in a state of threat, from inflammation, from excess oxidative stress, from dysautonomia, and that psychic threat then impacts us cognitively, emotionally, and also can create a lot of cognitive overload and shutdown, as well as post-exertional malaise, not just with physical movement, but as many know, with cognitive movement too. And then also understanding some of the gut dysbiosis and some of the digestive tract changes. Our gut being our second brain, it's where we make the majority of our serotonin, which is not just a feel-good chemical, but a think well chemical. So understanding some of the medical why behind it helps inform me to better understand, and I've been working with people around, so what do we do about it? There's an element of the cognitive overload. There's less gas tank in the engine, and it takes so much more mental energy, emotional energy, or physical energy to manage. And beyond just I can do it or I can't do it, or one of the art pieces over here says I could do my art for 7 minutes and then I was on the floor exhausted. So how to really figure out ways to manage energy different, looking at certainly pacing's a big one. And my PT colleagues look at a lot of heart rate pacing of how do we create less physical threat with movement. And so there's this biofeedback around, okay, if your heart rate gets to a certain level, stop, take a break, and really strategically build that. From a cognitive standpoint, it's so hard to turn our emotional or our monkey minds off. And so our minds don't get a break. And so using time-based pacing, using other strategic strategies, like how do we automate more of what we do, getting really savvy with frameworks around, some of the people I work with around different levels of delegation with collaborative AI use to offload some of the decision-making, filtering out, the brain, it takes a lot of energy to filter out just the background noises, let alone the background light. And so some of the people I work with use, loop ear filters, like musician ear filters, or eye filters. Our brain, or our eyes are our brain outside of our body. And so for some people like FL41 lenses, the same kind of lenses that people use with migraines or headaches sometimes can help filter, not just when the symptoms arise, but if we can decrease how much cognitive energy the brain's taking, then when we actually use the energy, it can work better. Some of the work I do is around recognizing that somatothreat. It's not necessarily, I'm not doing something that I think of as being threatening, but how to strategically pace to downregulate the body somatically throughout the day, strategically, where it's not just the symptoms telling what to do or driving, I've got to stop here, but how to get really strategic with sprinkling those downregulation or safety practices throughout the day. There's some great, apps and tools and ways to kind of simplify that. How we feel app, it's more somatic or psychosomatic focus, but there's some great body tools, breath tools in there that are 2-minute little downregulation practices. So finding practical things like that. And then as well as looking at ways to strategically engage. So my PT colleagues are looking at how do we use a Utah protocol, or how do we use some really strategic monitoring related to isometric exercise or progressing exercise in a very non-threatening way. And the same thing cognitively. Some of people get brain fog because of deconditioning. I haven't done my work in a while, or I'm not getting blood flow to the nooks and crannies of the brain that allows me to think deeper or for longer. And so getting very strategic with how do we engage cognitively, but not allow it to be a threat. So in PT, it's a little easier because we can watch the heart rate. Not easier, I don't mean that, but easier to get the biofeedback. So cognitively, for some people using brain training gaming platforms like Brain HQ, where the threat's not as much there, as long as we can get really strategic with engaging the brain, finding ways to minimize the threat and downregulate the body. Inspiratory muscle training is an exercise that's been studied and researched for years, used a lot more in Europe, but I've been using it in my practice for all kinds of other things for the last 10 years or so. And there's been a few more studies coming out with long COVID, where when we're breathing in against resistance, it's not just good for our breath, but there's studies looking at endothelial dysfunction, how we get blood flow moving and nitric oxide moving, inflammation, calming the nervous system. So for some people, I use it maybe for their voice if people are having vocal cord dysfunction because of COVID and upregulation, but also for just getting more blood flow and more activation in a very strategic, non-threatening way. So those are some of the things I work on.
Thank you. Good afternoon, everybody. Thanks for being here. Let me first thank Sally and colleagues for organizing this very important art exhibition, which really raises awareness of people, public, providers, patients and their caregivers about long COVID, which is one of the problems that currently we're having. And this is really timely and helpful. And thanks for inviting me to be here and giving me the opportunity to share some of the work we're doing at the state of Colorado. So as Sally said, I am Mirwais Bahij. I'm a medical doctor by training, but not a clinician. I've worked in the field of public health, and I am originally from Afghanistan. I'm new here, and I've been working for the past 2 years, more than 2, at the Office of Governor as policy advisor on long COVID and post-viral illnesses. Also, you may have heard of long COVID. I will ask later on Dr. Lai to just have a definition of long COVID for us, but just in order to establish the context, so we know that long COVID refers to new or recurring symptoms and conditions that people experience after contracting COVID-19, which can last at least based on the definition, based on the new definition, for 3 months, but it can last for months and even years, because the studies show that people even have had it for over 3 years now. And everyone can develop long COVID regardless of their age, sex, gender, their health status, disability, and but there are a certain number of people who are at risk of developing long COVID, like women, people of color, who are disproportionately impacted by long COVID. So to give you a little bit of background on the work we are doing here, actually, in its COVID roadmap back in early 2021, the Polish Primavera administration called for investment and research on long COVID, and the Colorado General Assembly passed a bill on, sorry, the General Assembly passed a bill on 2022, which is House Bill 22-1404, which authorizes the Office of Saving People Money on Healthcare, which operates under the Lieutenant Governor. Lieutenant Governor is the director of the Office of Saving People Money on Healthcare. So she's leading all the health efforts at the state level. So that bill authorized our Office of Saving People Money on Healthcare, where I work, to start work and examine long COVID. So I started work in late 2022, and the aim has been really to understand long COVID and assess its health, mental health, and socioeconomic impacts on well-being of Coloradans, to develop a framework to address them. So over the past 2 years, the Office of Saving People Money on Healthcare has engaged with different stakeholders, from healthcare providers to clinical researchers, public health people, patients and patient advocacy groups, policymakers, and academic institutions, to better understand the challenges of long COVID and to be able to develop strategies to address them. Oh. Oh, so in order to assess the needs of Coloradan, our long COVID efforts have focused on 4 main areas. So the first area we're focusing on is surveillance and epidemiology of long COVID, to know how many people are impacted by long COVID. A second area the state is working on is raising awareness and prevention of long COVID, so that we not only prevent people from developing long COVID, but also to prevent them from the worst outcomes of disease through accessing healthcare. And a third area, which I just said, is how we can improve access to care for people who are affected by long COVID. And a fourth area we are working is to examine, assess, and be able to address the socioeconomic impacts of long COVID on Coloradans. So this is the framework that we are working here on long COVID. So on epidemiology, we're working to know how many Coloradans are getting long COVID. We're developing a system to estimate the real burden of long COVID in Colorado, to evaluate the trends and demographics and patterns, risk factors, to identify the disproportionately impacted population, to estimate short and long-term care needs, and also to inform prevention and mitigation efforts. So our data collection or epidemiologic work is led by the Colorado Department of Public Health and Environment, and Colorado School of Public Health. CU Anschutz is one of the main partners working with us on this endeavor. So for long COVID surveillance, in order for us to know and be able to estimate the number of people who are impacted by this condition, we use cross-sectional health surveys, and we also use electronic health records, and also all payers claims data from Colorado. So survey data really can provide valuable information to help estimate how many people have experienced long COVID, how many are currently experiencing long COVID, as well as information about those individuals, about their characteristics. So we use data from different 3 surveys. One of them is the Household Pulse Survey, which was by the U.S. Census Bureau. The other is the Behavioral Risk Factor Surveillance System, which is a federal survey, but administered at the state level. And CDPHE, Department of Public Health and Environment, is administering that here. And also Colorado Health Access Survey by Colorado Health Institute. So these are the 3 surveys that we are using to gather data about long COVID. It is risk factors, outcomes, and everything. And also electronic health records. We are tracking hospitalization and emergency visits to see how many people come with a COVID and then how long they stayed in a hospital. They were just in an emergency room, discharged, went back, or they were admitted to the hospital. So we are using that data to see those patterns and get information about that using the ICD-10 code. There's a code, a diagnostic code for long COVID. So working on those areas to have information about those. And also we are using the all pairs claims database in partnership with Colorado School of Public Health. So on that, what we are doing is that because of the awareness, not all people who are having long COVID, because we do not have a biomarker, a test to say that this person has long COVID. So a lot of people are not officially diagnosed with long COVID. So what we are doing in order for us to get a real idea about the number of people who are affected by long COVID here, we're working on a predictive modeling with the Colorado School of Public Health through using and looking at the healthcare utilization patterns, use of medications after a COVID diagnosis. So this way, people who are not having a long COVID diagnosis, based on the healthcare utilization pattern, will be able to know the real number of people, including those who are negative, who do not have a long COVID diagnosis officially, but we'll find that through this predictive modeling. So the model will help us, which we're working. One paper was published a few months ago, and the second is going on. So Office of Governor, Colorado School of Public Health, and Colorado Department of Public Health and Environment, we are working on that piece together. And there has not been prospective studies where we start looking at patients and then check them for some time, apart from the Recover Initiative, which is a federal funded program that we are doing, and we have 2 sites here, one at SU Anschutz, another at Denver Health. So those are the epidemiologic work that we are doing here. So I just discussed about the household pulse survey. So what we did, we looked at the data for the last 2 years from July 2022 to July 2024, and we found that around 14 to 18% of all adults, not those who are having COVID, all adults have ever had long COVID. This means that they have had long COVID, but maybe they do not have it now. So this has been 14 to 18%. And at the same period of time, those who at the time of survey said that they currently had symptoms of long COVID, that was 4 to 7% of the population. Means that 4 to 7% of adult population are currently having long COVID, which Colorado follows the same patterns. So I will give you just the recent data that we have from the household pulse survey from August last year, which shows that 20.1% of all adult Coloradans reported having ever had long COVID, while 6.7% of them said that they currently have long COVID. And survey also shows that a significant number of these people who are having long COVID at the same time are experiencing activity limitation. So this survey showed that around 3 and 4, 75% of people who are having long COVID have at least one activity limitation of daily life. But 25% of them, and even over 25%, 1 in 4, 1/4 of people who are currently having long COVID, they're having a significant activity limitation, which they cannot perform their daily activities, school, work, etc. Which, if you put it in the entire population, that makes about 1 to 3% of the entire adult population. I just wanted to share with you the magnitude of the disease. One day I was discussing with Dr. Light, and we discussed that since based on this data, it means that out of 100 patients that a doctor sees, 20 of them may have had long COVID. So the doctors need to be cognizant, the healthcare providers need to know about long COVID, something that we are currently working at our community of practice to have a long COVID aware sort of certificate, something so that healthcare providers at least be aware to do the right referral or at least rule out long COVID, and so that people do not experience the healthcare fatigue that they have had, because it is something that initially when people were going to see doctors, they were saying that it is something in your mind. You may have heard that, and that was creating fatigue. Plus, you're going to your primary care provider, they were referring you to one specialist, another one, and finally, after a year, 6 months, or over a year, you knew that it is not that thing that we were thinking, it is something different, which is long COVID. So the course of disease, the course of treatment, everything is different. So that has really made a healthcare fatigue, and we are working towards that. I think I took a lot of time.
Okay.
Yeah, thank you for that. Since it's my third language to speak English, this is also one of the challenges. This is another thing that takes 20% of my time at least, believe me.
Mike.
Oh, so briefly telling you about the second area of work that we said, which is awareness and prevention to mitigate the number of Coloradans impacted by long COVID from growing. So we are trying to raise awareness about long COVID and its risk factors to prevent people from infection and reinfection through vaccination, because that really helps with not developing long COVID, and also to prevent from the worst outcome of disease through helping people to navigate healthcare services and go and seek care. So our awareness efforts really include long COVID webpage that we have. It is housed at the Colorado Department of Public Health and Environment. You can find a lot of information about long COVID, its risk factors, symptoms, and not only how to get care, but also disability services, public benefits, social services that are there. So you can go there and check it. I will share it with Sally so that she can share it there. And also through a grant that we have, we're working with the community of practice. So we are working with healthcare providers here who are knowledgeable, like Dr. Matthew and colleagues here, about long COVID, in order to transfer this knowledge to other healthcare providers, particularly primary care providers, family physicians, particularly those who are working on frontiers and rural areas. A third area of work which I said we're working is to improve access to care for long COVID patients to ensure they have coverage of the care as well. So we work with clinicians from long COVID community of practice, as I said, to learn about the barriers and discuss how we can provide better care for Coloradans who are suffering from long COVID. So through discussions and learning from the literature, we identified 3 main barriers for accessing care for long COVID. So the first is healthcare navigation. Most of the people don't know where to go and seek care. So healthcare navigation is one of the issues. A second is provider knowledge. Since knowledge around long COVID is evolving, it is something new, we still don't know much about it. So there is a gap in knowledge of some of the healthcare providers, particularly primary care and all those. And the third area that we found was insurance-related cost and administrative barriers, which is something that, because for long COVID, clinicians are here, we do not have a cure, a treatment approved by FDA now. And this gives an excuse for payers, for insurers, not to pay for the experimental treatments that has shown, as doctor was telling before about the hyperbaric, and there are a lot of other experimental treatments, but insurance does not cover them. So we are working towards all those with the federal government and here at the state with our counterparts. Healthcare policy and financing, division of insurance, we're working here. To improve healthcare system navigation, and also working how we can educate more healthcare providers to be equipped, be resourced to be able to manage long COVID patients, if not treat them. So fortunately in Colorado, we have 4 long COVID clinics. There are 3 multidisciplinary long COVID clinics, 2 of them in Metro Denver. One is by UC Health in Aurora. The second one is by National Jewish in Denver. A third one is in Fruita in Western Slope. And a fourth is where Dr. Matthew leads. It is the UC Health Long COVID Clinic in Greeley, Loveland, that they are seeing long COVID patients. They really lead the way in providing treatment and care for long COVID patients alongside other specialists and some primary care providers who are working at Kaiser and some other areas, and also at Anschutz School of Medicine. We have some colleagues who are working on long COVID. So in 2023, the UC Health Long COVID Clinic applied for a grant from the Agency for Healthcare Research and Quality to implement and evaluate models for delivering comprehensive, coordinated, and person-centered care for people with long COVID. So the aim was to improve access to care for people. And what really this project does is it connects a specialist, long COVID specialists from these 3 clinics, multidisciplinary clinics that we have, pulmonologists, cardiologists, and all other specialties, connecting them with peripheries, with primary care providers through e-consult, through telehealth, to help them with the cases that comes. So currently we're connected with 3 in a pilot phase, and by the end of this year, we will be connected with 30 more clinics across Colorado. So these multidisciplinary long COVID clinics will be providing them trainings and case-by-case education so that they be able to manage long COVID patient, do the right referrals, and this way we will be expanding access to care here in Colorado. The fourth area, and this is the last area, believe me, is assessing the socioeconomic impacts of long COVID. So as we all know, in addition to poor health, disability, morbidity, long COVID can cause a series of socioeconomic impacts on our daily life, inability to perform our daily activities, such as attending to school, going to work, performing household activities, socializing with friends and families, so on and so forth. So we worked with the Colorado Health Institute and added a few questions to the Health Access Survey, which is run every other year, which has a 10,000 sample size, which is a great, credible survey. So we put a few questions there to gauge not only the health aspects and how many people are impacted, but more importantly to look at the socioeconomic impacts of long COVID. So what we found there was that the survey data showed us that survey showed that over 14% of people who had COVID-19, they developed long COVID, which was around 3,000 people based on that survey. Means more than 300,000 Coloradans had long COVID at the time of survey. And which is important is almost half of them, 45.7% of them took time off from work or school, which is 145,000 people. And over a third, 33.4% of them reduced hours at work. 6.6% of them, which is around 20,000 people, applied for disability because of not COVID, because of long COVID specifically. And 8% had got disability benefits, and 23% faced other challenges and other problems. Survey data also showed us that those with long COVID symptoms were 3 times more likely to experience housing instability and 2 times more likely to experience food insecurity than people who are not having long COVID. So we'll work here to examine the socioeconomic impacts of long COVID, particularly on the workforce, which I said that it is impacting half to more than a quarter of people who are currently working, or they have lost their jobs. So the aim here is to support employers and workplaces to understand long COVID and explore strategies to foster more inclusive workplaces for people with chronic illnesses like long COVID. So what we'll be doing there is to work with the employers and business community to know what long COVID is and to help their employees, workers who are working with workplace accommodations, because people who are having long COVID, they may be able to perform the work, but not in the schedule of 8 to 5. They may need paces, as was discussed here. So we're working towards that so that we keep people economically active on that one. Yeah, this was all the work that we were doing. And one of the accomplishments, since we were working through a whole of society approach. Our win as one of the leading states on long COVID is that it is not only the government but that is working, because in the state governments, a scarcity of resources is one of the problems. But here we are working with the state agencies and other stakeholders, so private sector, healthcare providers, academic institutions, they come together and work. And one of the accomplished was the establishment of the long COVID community of practice. We are specialists from these 4 long COVID clinics. One of them, Dr. Matthew Light, come together, and also primary care practitioners from other practices, people who are working on education of healthcare providers like ECO Project, and colleagues from the Colorado Hospital Association. They come together, meet regularly, and the aim is to discuss long COVID management, recent developments, to learn from one another, and facilitate rapid knowledge sharing among one another, and standardize long COVID care across the state, and also make recommendations for a state how we be able to improve our surveillance system and also improving access to care. So these are the work that we are doing, and the community of practice is really doing a great job in terms of educating healthcare providers so that they know. Last week we had our monthly meeting and we come up with a clinical tool, and we're planning to share it with the all healthcare providers at the peripheries, with primary care practitioners, so that they know at least what long COVID is, and to be able to manage and do the right referral for their patients. This was a long explanation of what we are doing. Sorry to taking more time. Thank you.
That was great. That gave me time to think about what I should say. So that's perfect. I'm Matthew Light. I'm one of the pulmonary critical care doctors in Northern Colorado. So I work mainly out of Loveland. And I was trying to think about what I should talk about today, but I wanted to really hit home on what our clinical program is doing, and then let my partner in crime, Michaela, talk about the long COVID, what we call information discussion and support group. So I'll get into it a little bit. I think, a number of years ago, if you had told me I was going to be a doctor that was going to take care of, we didn't know what long COVID was, but chronic fatigue syndrome is one of them, I would have thought that you were probably crazy. But the journey with me and long COVID really started with a very simple question, which is, who is supposed to take care of long COVID patients? And I don't know if I really know the answer to that. Is it a cardiologist? Is it a primary care doctor? Is it a rheumatologist? And unfortunately, with our kind of reductionist medical system, you see specialists that specialize in different organs, and I'm not sure that that's the right approach to long COVID. Unfortunately, there are people struggling with symptoms across a wide variety of organ systems and issues. And so that was the main question that got me interested in long COVID in the first place. And the other thing that I think is really important besides that piece is long COVID, there are a lot of uncertainties. And to be fair, there are a lot of uncertainties in medicine in general. I think the further you get in medicine as a physician, at least in my case, the more I know that I don't know, which is part of one of the interesting things about medicine. But at the same time, I think our standard paradigm of taking care of patients to some extent is failing. One of my concerns is the amount of doctors, the amount of subspecialists that patients are being referred to, the amount of testing that goes on. And not that there's anything wrong with diagnostic tests, but patients are developing real fatigue. They're spending a lot of money and an awful lot of time to have a lot of tests done. And at the end of that, in some instances, they're being told that there's not a problem when the patient's sitting there going, I guarantee you there's a problem. So the way I approach that is we don't know what we're looking for yet, and I hope that changes. And so what we do, or at least what we try to do in our long COVID clinic, and I think working on standardization is super important. But we essentially try to problem solve and we try to tinker. And we try things with the goal of raising people's quality of life. And obviously we hope for a lot, but we shoot for a little and we go piece by piece. And I think that's really important because just doing diagnostic tests, the yield is not very high. And so we need to try things to get people feeling better. The criteria we look for in our clinic, and I think most people do this fairly rigorously, is three things. So we like to see that there's some evidence for the interventions that we're using. Now, there's not a lot of evidence in long COVID. There's not a lot of studies of interventions in long COVID, but we like to see at least some inkling that there is some rationale for us using these therapies. So that's important. And honestly, I could compromise on that because a lot of the patients come in with new ideas and certainly we can talk about them. The second big thing is safety. And I think this is by far the most important thing. So we cannot be using therapies that are not safe for patients. And this is something that I worry about all the time when people are bringing me new information or looking around kind of on the corners of the internet about what to do for their long COVID. And I just really want patients to be safe. And I realize that there's some desperation here and people are willing to roll the dice. But ideally, we are looking for safe interventions. And then the last one, which we touched on before, is accessibility. Like I would love to try hyperbaric oxygen on all of the patients pretty much because I think there's some amazing data for that. Unfortunately, I can't ask everybody to pay $12,000 for hyperbaric oxygen, and that's just out of reach for a lot of people. So those are the criteria we try to use. And then I think the most important thing is finding someone to stick it out with you. So trying one or two things for long COVID probably isn't going to be effective. I mean, I think the biggest issue with long COVID, we say this all the time, I guess, is not that we don't have any therapies for long COVID. It's just everybody responds so differently to therapy. So we have to try things. We have to make sure that they're safe. And when things aren't working, we have to get rid of them and move on to the next thing. And along those lines, we have other concerns. So we need to make sure that people aren't taking too much medication. Ideally, we're looking for interventions. Some of them may be medication, but ideally, we're looking for other interventions that have nothing to do with medication because we simply can't afford to give people this much medicine and run into issues with side effects, polypharmacy, et cetera. So I think that's really important. And something that we've been really interested in recently is just, well, not recently, but focusing on pillars of health. Ideally, one way of looking at the situation is you go to a doctor, you tell them what the problem is, or they kind of deduce that the problem is long COVID. And then they give you a medication and that's the end of it. But that standard paradigm doesn't work for long COVID very well because we don't know what the problem is and we don't have the medication yet. So at least in my perspective, one way to get around this issue is focus on pillars of health. So we talk about diet a lot. We talk about exercise a lot. We talk about sleep a lot. We talk about even other pillars of health like mental health, spending time outdoors. And the things that I think how that could work is if you could optimize all of those things, not only is it possible for you to feel better and for the body to heal itself to some degree from this unknown problem, but also what I like to think is that if you do those things, you will be better off than you were before. Like let's say you recover, you will be better off than you were before. And so I think honestly, everyone should be focusing on these things regardless of if they have long COVID or not. But if you have long COVID, it's not about taking a pill. It's about how can I restructure almost everything in my life to optimize health, feeling well, well-being, etc., and really reprioritizing everything. So that's my approach to long COVID. I'm really fortunate to get to work with Wace and Dr. Jolly and some of the people at National Jewish, and we're really looking forward to expanding our long COVID services in Northern Colorado. So hopefully that's coming soon. But I guess the last thing I wanted to end with was the incredible people that I've met because of long COVID, not just colleagues, but meeting long COVID patients is incredible. I mean, Michaela's going to talk about our support group, and I always, sometimes I what's the word I want to use? Sometimes I grumble to Michaela before the support group meetings. I'm like, oh, I'm tired. I can't do this tonight. and I just don't want to do it. And then after the support group, I'm always so energized because I'm like, look, we need to look into that. What's going on with this? How can we help this person? And I think overall, I'm really grateful to have taken this step. Caring for long COVID patients is amazing because they are very grateful. They just want a little bit of guidance. They are super smart. They are super motivated. It's unlike a lot of other patient populations. So I think it's been a surprising twist in my career. But yeah, I'm looking forward to especially 2025, although it's already, what month is it? June now? We need some more data. Yeah, I'm looking forward to 2025 and 2026. And I just really encourage everyone with long COVID to find a provider that they can trust that will work with them on issues and try to work through some of these problems, regardless of what organ system we're dealing with. So.
Good afternoon. My name is Michaela. I am here because I am a long COVID sufferer myself. And so listening to everybody prior to this, a lot of that has resonated with me. And if you have long COVID, I'm sure it's resonated with you as well. I was 2 years into my long COVID journey before I met Dr. Light. And a few of the art pieces behind you guys really spoke to me in that 2-year journey before I met him. The blank calendar in particular, because I could relate to, I had my doctor's appointment. I felt absolutely terrible. I'm waiting for that doctor's appointment. I see my physician, we have a plan, and then it's like, we'll see you in 6 weeks. And I sat at home like, what am I supposed to do for 6 weeks? Like, I don't feel better. This isn't helping. And so that's what the blank calendar felt like to me, was like that waiting for the next doctor's appointment that I had. And then the roller coaster one spoke to me too, because you have those good days and you're like, yay, I'm better. This is like the uphill. I'm going to be healed now. And then you have the drop where you crash and then you're not good again. And sometimes I tell people that I feel like getting better, it's great. It feels awesome. But then when you crash again, it's even worse because you remember what it felt like to feel good for a few days and then you lost it again. So a lot of that spoke to me, having the multiple doctor's appointments, the scans that were normal, being told you're normal, go home, everything's okay. That all spoke to me really huge. And when I met Dr. Light, he was the first physician who looked at me and said, I'm so sorry that you are dealing with this. This has to be difficult. How can I help you? And that just to me was just like that breaking moment of like, I finally found somebody who listens, understands, and will validate what's going on with me. So I think you even said in my appointment, I almost made him cry, telling him how I had been struggling for the last 2 years. So when I met him, it was just a normal doctor's appointment. And then I got my first COVID infection after having long COVID. And I called his office, what are we going to do? And then when he called back, he said, hey, do you want to start a support group together? And I was like, yes, I do. And so together we built the long COVID information discussion and support group. The idea for the information and discussion was hugely by Dr. Light because of all of the research that us long COVID patients do on our own, all of the things that we try in between those doctor's appointments that, yes, may be healthy and maybe work, but maybe aren't so healthy and could be dangerous for us to try. So we started the support group with him doing the presentation. So we have a topic that we have picked out for the month. He does tons of research on it. And then he presents for the first 30 to 45 minutes of the group on that topic, bringing in research and data and then saying, this is my thoughts on what you would do with this type of treatment. We've done 16 presentations so far. We have a suggestion form that you can fill out for topics that you want us to talk about, and that's where we get some of our ideas. And then we try to find a specialist in that area. So we've had Renee King from Anschutz. She did one on physical therapy and pacing and chronic fatigue. We've done hyperbaric oxygen. We had lymphatic massage where we had somebody who specialized in it come talk to our group, heart rate variability, pacing, viral reactivation. We did nutrition last month, or this last month because it's June now. We did nutrition for May, which was great. And June's going to be acupuncture. So if we can't find a specialist in that area for the topic, then Dr. Light takes it upon himself to do that research because he likes to educate himself as well to share with everybody. So like Sally said, our contact list has grown to 400 people. We actually now have 2 internationals. We have a UK member and a Canadian member. also. And people just, when they email our group, they're just so desperate for somebody to help them, to support them. And I think that we get a lot of feedback as far as how thankful they are for the information they receive, but also being able to come together as a community with people who understand them and having that time to talk to each other, ask ideas of what's worked for them or how they have fixed things. But I think it's been really great for our community and those in our states also to get together to do that. We offer in-person and virtual to join, and we do it every second Tuesday of the month from 5:30 to 7:30. So if you guys have not reached out to us and you want to, then we can get that information for you guys as well. And thank you, Sally, for putting this together. Sally, I think you reached out to us May or June of last year with this idea. So she's been working on this for a really long time. So hands down to her for she got it together, and this is awesome. So great job, Sally.
So the question was, have the support groups been recorded? So initially we were trying to disseminate information because we realized that a lot of patients want to re-review the information that's presented. Some of them can't make the visit, some brain fog, tiredness, etc. We need a way to get people the information so they can go back and dig deeper themselves. And that's honestly what the group is all about, is education. So that's great. We have not recorded until recently. So our previous policy was we would send out the PowerPoint slides and let people peruse things that way. More recently, and that was mainly an institutional limitation why we haven't been recording. Now I think we have a recording strategy. So from here on out, the groups will be recorded. So.
Nobody can hear you. I'm sorry.
Thank you. I'm sorry. Okay. Well, I'm really struggling to find a primary care physician that actually truly believes in long COVID. He's come out and said he does not believe in it. And he doesn't even believe in fibromyalgia or chronic fatigue, any of that. It's all psychological. So he had a psychiatrist actually call and wake me up in the morning at 9 o'clock one morning, scared the daylights out of me. The way that she had worded it, I thought I was going to actually be admitted. I am struggling with my eyesight. I've had surgery on my eyes and I didn't make it any better. So I can't hardly drive. Memory loss. I've lost 20% of my weight in 1 year. Gosh, Gary, my heart rate, I am like struggling with my heart rate. To go from a bedroom to the kitchen will go from like 70 to 159. And I'm not getting any help. He won't help me to find anybody. I just need to find a doctor that believes in me like my other doctor did and can like take that and help me. I can't watch my grandchildren anymore. They're twins. I can't see to tell them apart. So I need help.
From a personal experience, I also, when I first started with long COVID, had a physician that I had been with for years. We had a great relationship, and same thing. She absolutely did not believe in it. As hard as it is to say, I would change your physician because I can't say that there's somebody that you can find that specifically says like I belong in long or I believe in long COVID. You can find on the website their personal interest, and some of those might say long COVID, but I would encourage you to find another physician. If you don't need a referral to go to another location, then that's even better. You can just make an appointment with somebody. But that would probably be the best thing. There are some stuff that you can do without a physician to just get started. With you talking about your heart rate, you really should start with the pacing. There's information on the Work Well Foundation website that talks about how you can pace yourself, different things you can do to decrease your heart rate, making things easy for yourself. Like for me, it was, why do I need to go to the grocery store when we now have grocery delivery? Just order it. You don't get to go pick out your own stuff, but you're saving your energy for other things that you want to do. Another thing is sitting down to shower. So that was a huge thing for me. Is Renee King actually told me you save 25% of your energy if you sit down and shower instead of standing. And so then you have that energy for something else, and it's also keeping your heart rate down. So just a bunch of little keys that you can do on your own without the physician until you can find somebody who can truly help you.
Well, I think, unfortunately, there are just providers who are not there yet. It's a little bit of an interesting situation, I think, because this isn't the first disease where we had to rely solely on patient reports of their symptoms, including pain, shortness of breath, and so I think we're obligated as physicians to take patients' word for what is going on with them, and not believing in long COVID, I think, is an unusual situation. Unfortunately, I think people still run into those providers, but that really kind of creates a barrier, and it basically means I can't help you, I think. So, and then I was just going to mention, so we do occasionally, at least to my clinic, get referrals through the long COVID information discussion and support group. So people often email in, and then we work with our schedulers to get them scheduled in clinic. And then I think what's really exciting is through work with Mirwais and Sarah Jolly and others, hopefully as we expand our clinical operations, we'll have a little bit more help with that kind of stuff. And so one of the things that's been discussed is a clinical navigator that could help us with our long COVID program. And honestly, in addition to building the long COVID clinical program, what we want to do is fuse the clinical program and we'll call it the support group, even though it's not just a support group, so that we're reaching as many people as possible and people aren't falling through the cracks. So that's kind of where I think hopefully the next 6 months goes. But we're just trying to get in as many people as we can. But I do think, as Dr. Bahij mentioned, the education piece is super important, because 4 clinics in Colorado cannot be the only people that can diagnose long COVID, and they cannot be the only people that can try long COVID therapies on people. That's just not going to work for this state, and that model would never work for this country. So.
The question is there a directory that people can go?
Yeah. So if you go to the our long COVID website, if you just type long COVID Colorado, it just takes you to the long COVID webpage, where we have listed these now 5 clinics. There is one pediatric long COVID clinic at National Jewish, which we didn't have for some time. So we're having now 5 clinics that are seeing long COVID patients. They're listed there with their email address and contact details, where you can call or email them, or there's a form so that you can get an appointment. And there is another link that shares information about other healthcare providers who are operating in this state. It is not by us, but it is by another institution, actually an advocacy group, but they are updating it. Like your clinic from at Boulder is also listed there. So when I first came, I looked into that, and I found, because I was new and no one knew about long COVID then, because it was 2022. So I went and found that there are certain clinics that are operating, and they're seeing people with long COVID. So that is there. And currently we are working on a resource guide not only to put it in our website, but also as a pamphlet, as printable, downloadable stuff, so that we have it downloaded and share it with all health care system, other places like counties and everywhere, so that people, we can raise awareness of people through this. And one of the main things there is a list of the long COVID clinics who are operating at this state. But as Dr. Light was saying, these 4 clinics that we have, they're not, sufficient, because they have been able to visit more than 10,000 people, between around 15,000 people. But when we say that, for example, 5 or 6% of adult Coloradans currently having long COVID, we are talking about 250 to 300,000 people currently having long COVID. If we take 20% of them needing care, that is a lot. So we're working towards that. And one of the things is, as we discussed through our project that we are currently working, we were awarded this nationally among 9 healthcare institutions nationally that got that award, and one of them was Colorado. So through that, we're connecting with 30 more clinics, tertiary, primary, and secondary, so that their clinicians know about long COVID, plus other training programs that we are having there, so that everybody, every provider, if they're interested. And now we're working to see how we can have primary care providers, or how we can encourage them to undergo these trainings. Because when it comes to primary care providers, they are sort of bombarded with tens of specialties information. They need to have information about diabetes, pulmonology, cardio, gastrointestinal, and others. But one of the things that I was discussing, and Dr. Light gave me the idea, is how to incentivize. One would be, for example, for the healthcare providers to let them know that among 100 patients that you see, 20 of them may have long COVID. So this is why you need to get a little bit flavor of long COVID, so that you be able to see long COVID patients. So these are the efforts that we have started. Healthcare navigation is really important, and we are not only working on healthcare navigation, but navigation of other social services, because when people having long COVID, they may be having disability, so they need information about housing, food, financial, other programs that are there. And we'll soon have that resource guide to share with people, so that people can have this and get the information that they need. And there are certain organizations who, when you call, they will help you find the resources, and even they can help you with applying for those benefits. Like for those who have lost their job, applying for social security benefits and stuff like this, or for people who are applying for Medicaid and other stuff who have lost their job, and as a result of that, they've lost their insurance. So there are certain institutions, organizations that are working, and the Colorado State is paying them, for example, through our disability program here. We are providing grants, and there are organizations that are providing this information. I hope.
Can any of you speak about teenagers and POTS? Not only what it is, but how we can support and help these kids, and what kind of treatments are available to them?
I'll speak briefly. My physical therapy colleagues work a lot with POTS, dysautonomia, and that's a common thing that comes up with long COVID. So whether teens or whether older, so a physical therapist that would have some training in that. From a therapy standpoint, there's certain protocols in place, looking at certain biofeedback monitors to help people with standing up, with movement, with the example you offered earlier, when your heart rate shoots up just getting up, let alone from the bedroom to the other room. There's certain protocols in place that the therapist can work with, and really meeting individual needs with that. I might pass it around some medications used.
Yeah, I think postural tachycardia syndrome, I think to some degree is a little bit challenging in the sense that a lot of our long COVID patients, they seem to have issues with high heart rate, and it seems to be creating problems for them, especially with changing position or physical activity, and it seems to be a big barrier. I think conceptually doing a lot of testing for postural tachycardia syndrome may or may not be useful, just because if you don't meet technical criteria for postural tachycardia syndrome based on tilt table testing, if you go down that path, then you're left with nothing if you don't meet criteria. So usually what we do is just take a clinical history and try to sort out, why is the heart rate a problem? Is it kind of the primary issue, or is it a secondary issue, and then proceed from there. And I think there are a lot of great medications and then non-medication interventions for postural tachycardia syndrome. So like, for example, like one of the things that helps my breathe, I didn't mention I have long COVID. My case is pretty mild these days. But one of the things that I noticed through trial and error that helped my breathing the most was staying hydrated, which doesn't make any sense except in the setting of postural tachycardia syndrome and what we call neurovascular dysregulation, which is kind of a new concept. So I think there's a lot of good medication, and then there's a lot of good non-medication interventions. Another good example, like, which I think you guys probably do, is figuring out ways to exercise differently. So like for me, I used to do Peloton. I used to like to run, but just decided to get in the pool because I need to exercise horizontal. So there are definitely ways to make that a lot better. So I think from a testing standpoint, there are some limitations. I think there's only a limited number of tilt tables in the state, maybe one. I'm not sure. I'm not sure doing that is super fruitful, but I do think there's a lot of good interventions for POTS. So, Michaela, you should probably.
A few other recommendations I would say is not necessarily just staying hydrated, but electrolytes. Obviously, you need to know your medical history and whether that is appropriate for you to increase your electrolytes. But that is something that you can add into your drink, just those little like IV hydration packets. TED stockings can help because it helps keep that blood flow up to your brain instead of pooling down in your legs. And then I can't think off the top of my head what the protocol is. I don't know if you know what a Utah protocol for that working out. But a lot of it is just starting with like floor exercises. So I think a lot of people try working out with like, I'm going to run on a treadmill or I'm going to ride a bike. But really, you need to start your exercise protocol with laying down instead of those standing or sitting exercises. And that will help you get that stuff built up a little bit quicker.
So we have an online question here, and it's kind of long. When you have a lot of different medications or therapies you're trying, how can you identify which ones are most effective and worth the energy? And the second part of that question is, or to elaborate that question further, how can you make sure different specialists are aware of the little things covering up the text of what the others are thinking, doing, prescribing when you have an energy impacting condition?
That describes a patient that I always frequently saw in my mild head injury population, which is also an injury of energy. And long COVID similarly has a lot of overlap with that, which is an injury of energy. And when people do come in having previously been treated with multiple practitioners, having been given multiple medications, and we see that kind of polypharmacy, that's one of the things that I used to practice is one, taking a really good history of when did you start that medication and what were the effects, and to see along with the patient which medications they're already on weren't really all that valuable, and then eliminating them, but eliminating one thing at a time, really making sure you're controlling for the variables of seeing what made a difference and what doesn't as you take those medications off. And oftentimes you can see people improve just by eliminating medications because most of these medications have side effects. That was one thing. There was a second part of that question about the injury of energy. I'm not sure if I can't remember what that was. Oh, that is really hard. I don't know. Do you have a better answer to that than it is really hard? I mean, sometimes yeah. I've certainly tried to communicate with other practitioners, and sometimes they're surprisingly very open and want help themselves dealing with this very complicated patient, and then will allow me to take over. Sometimes I get yelled at for trying to get involved in areas that maybe they viewed with their territory. So it's a very complicated socio medical territorial issue for physicians to deal with. That's my best answer.
I'll just add in from a therapeutic lens. I mean, I have the fortune of working right next door to the physical therapist, so we're able to talk a bit. But even if we weren't talking, there's a big thought with us is you only have so much energy, and each thing takes energy. And this isn't something where we're rebuilding a muscle. So more is better. Some paradigms are like, do more, work more. That's how we get better. And this is very much a create less threat. So like Michaela was saying, you know, exercising on the floor first and not doing it 5 days a week and not doing it. So the therapist who will recognize the energy deficit, and just like all physicians aren't trained the same, all therapists aren't trained the same. Some speech therapists or cognitive therapists are trained around, let's exercise the mind more. This is a deconditioning thing, or let's work on the skill, or same thing with PTs. And in some stances, that's correct. But a lot, to me, my therapeutic role is how to help people cognitively consolidate and use tools and visual routines, whether that's an app like TickTick to help organize what you're doing so that providers can see it, therapists, you can see it, where you're not having to do the mental energy of managing all these different things to a point of depletion. So trying to work with providers around that as well to get some help around that.
One additional thing is, as they develop these long COVID clinics, hopefully they're multidisciplinary, and hopefully they do have a physician on board who communicates with the therapists. And if you could find one of these clinics and they take over your care, that's one way to circumvent having multiple physicians prescribing multiple different things.
Yeah, I think this question brings up a couple interesting issues. I think it's super important to limit medications. I mean, we've seen people come into clinic, you know, accidentally taking 3 antidepressants, and things like that. So the first step is to get rid of all of that stuff and make sure that anything that you're taking actually has some value. So another one that we always look at is beta blockers in chronic fatigue syndrome. So if you're on a beta blocker for high blood pressure, and these are terrible high blood pressure medications, then, you know, we need to reevaluate that strategy. So the other thing that I think was brought up by a lot of people was you need to make sure that anything you start is effective. So the question is always, is the juice worth the squeeze? And there's a lot of things that you could do in long COVID with maybe some marginal benefit, but those aren't really the things that we should be looking for. We should be looking for things that make significant benefit. And then the other part of that is, if they're not, they need to go. Like, so you need a trial of those things, and then they need to come off. Otherwise, the medication list builds and builds. And I think this whole issue really speaks to our discussion about access of care and how to get everybody seen for long COVID. It's one way of looking at long COVID is we need to see all of the 200,000 people in this state with long COVID and get them access to care. But the other flip side of that coin is, given how complex it is, we also need to follow those people every 6 weeks. And 6 weeks seems like a long time for long COVID, but like in other clinics, like 3 months is a standard follow-up, which means realistically, if you're seeing a patient every 3 months, you're making 4 changes to their regimen per year, which is not going to work, at least in my opinion, for long COVID, because we need to try multiple things. So that requires a lot of communication. That requires a lot of trial and error. And so I think we need to find strategies where one clinic, not a bunch of subspecialists, are trying to care for one long COVID patient, whether that's a clinic with a provider who can kind of fill the role of multiple different subspecialists, like primary care, or a multidisciplinary clinic. But again, like we were kind of talking about, the model of seeing every subspecialist and then trying to get those people to coordinate, I don't know if that makes a lot of sense. And I guess my last point is we always try to do things one at a time. So if we're taking off a medication, let's try that for 2 weeks and see how it goes. Okay, great. You didn't notice any problem. Okay, we're done with that medication. Now what's our next step 2 weeks later? But yeah, combining a bunch of things, doing multiple things at once is inherently problematic, because our outcome, unfortunately, at this point is how do you feel? So that's not a hard outcome, and that's going to fluctuate as people get sick or they have life stressors, etc. So we need to be careful with that.
From my personal experience with coordinating between doctors, I think the best thing is take a support person with you who can listen in, even if you're capable of taking in that information by yourself. I'm a nurse, I work in the healthcare field. I can't take care of myself for whatever reason that is. And I think most healthcare providers would even say that. So it's nice to have that support person for 2 different reasons. One, they can take notes for you, but also when you come out of that appointment, ask them what they took out of the appointment, because it's a lot different than what you took out of the appointment, because you're sick and you're the one dealing with it. So having that support person is huge if you have that available. And then keeping a track of notes as you're adding and removing stuff. How did you feel day by day? Because when my appointment comes up, I'm going to feel completely different than when I changed that medication, and you won't remember it. So keep a track so that you can go back and be like, oh yeah, I put in my notes that right after starting this medication, this, and this happened. I've done it for the 3.5 years I've been dealing with it. And I've looked back all the way to year 1 and been like, oh, this makes sense now. Like as I'm reading through it, that was the problem back then. So that helps also.
Visual planners and journals linked have been really helpful, because often we're used to having an appointment planner, but that's really just appointments. And then we have notes other places, and that takes a big mental load. But some of the old school 2-page planners that allows you to put together and integrate both appointments, tasks, breaking down tasks, routines, and some of that, how you feel, and finding something where you can see it. Again, there's apps. I reference TickTick as one if people are more electronic, but more often than not, that paper that integrates all of that has been really helpful.
One thing I want to add is that as per the World Health Organization and CDC guidelines, so they say that this healthcare provision for people with long COVID and other infection-associated chronic diseases should be in a coordinated, multidisciplinary way. At the center of it should be the patient and someone, a provider that knows the patient well, like your family physician, your primary care physician, because they know the language to communicate with other providers. So if you have someone central, you go to them, and then you go to a cardiologist, because they may give you some medicine you don't know. The other day you go to a pulmonologist, you can get something that are conflicting. So a lot of medications that Dr. Light was putting. So based on those, if you have someone at the center of this to work with you, plus what Michaela said, someone that, a caregiver that can go with you, and the journal thing that you mentioned, they all can help. So someone that can help you from the medical field, and that would be your primary care provider or family physician or whatever you call it. And I like initially what Dr. Light said, don't seek for specialists and subspecialists, but someone that trusts you and you trust them. This is the core, I believe, based on the experience that we have. But again, I'm not a clinician.
Hi, thanks for being here today. I'm a patient of Dr. Light's, and the most recent medication that was prescribed has been held up by the insurance. And I know this is kind of a mundane question, but first medication we tried, it didn't work. And now this one's been on hold now for quite some time. And I don't know what to do about that. I don't know if you know what to do about that, but I see that as a real problem. And I guess the other thing is I've been receiving the notes from Michaela on the every second Tuesday. And I have trouble. I can't get on Zoom because it just doesn't work for me. And I'm sure it's something I'm doing. So I heard about this meeting through a counselor over at well, a different facility in Fort Collins and Mountain Crest. I have a counselor at Mountain Crest Psychiatric Hospital, and I see a psychiatrist over there as well for depression, anxiety, those kinds of things. But the counselor who I work with over there messaged me about this meeting today, and I don't know if there's a way to send a notice out that, hey, we're going to be doing this, because had she not messaged me, I wouldn't have had any idea this was going on. I don't know how everybody found out about this, but that's how I found out about it. So I don't know. Maybe I'm asking for. I live in LaPorte, and so LaPorte's kind of a haul from Loveland, but so we don't get the paper or anything like that. But anyway, I just wanted to say I don't want to continually bother you about insurance holdups because I know you're a busy guy, and I don't know what to do about it, and I don't know how to get on Zoom, and my wife knows less about computers than I do, and I don't know a whole lot, so I don't know if there's excuse me, if there's going to be more meetings like this, I'd like to find out, other than my counselor at a psychiatric hospital. That's all. I don't even know how she found out. That's all I got.
Well, let me first say we're glad you did find out. We did make a big effort to make this public. It's in the city of Loveland has a calendar. The Northern Colorado Lifestyle magazine, I think it is. It's an online. It has a calendar. It's in there, and there was a big article in the Loveland Reporter Herald, and I know UC Health put out a big notice about it for people who utilize UC Health. And it is a challenge to get the word out. She said it's just to internal employees. Oh, so it didn't go out to patients? No, it did not go out to patients. Yeah, I think it did. Did it? Oh, yes, we put lots of, so someone in the audience said they found out about the Long COVID Colorado Clinic on Facebook pages. So I did post a lot on different Facebook pages. It is always a challenge getting the word out about different events. This is the first time this has been done, so that also adds to it. A lot of it was word of mouth. Uh-huh. Okay, that's fair. Okay,
I would like to address your first issue, which was getting the insurance to cover it. That is really difficult. But I have found over the years that it's the squeaky wheel that gets greased. And so when the patient themselves keep calling and calling and calling, you call your insurance rep. I'm assuming you have Medicare. Do you have a supplement? Yeah. So find out who your insurance rep is and start calling them. In fact, and the reason I wanted to say this, I have a long COVID patient now who we've been treating for a while, and she's gotten 100% coverage through insurance. And I have no idea how, other than the fact that she annoys the heck out of us. And I know that it's probably she's the squeaky wheel that gets the grease. And, you know, docs don't do so well calling for you as much as a patient has success calling themselves.
think we were just talking about your medication on Thursday, and for this sounds crazy, but at one dose, insurance is hesitant to cover like one size pill, and at another size pill, they are willing to cover. So I'm hoping that gets resolved soon. So anyway, yeah. And then I think this really speaks to what Mirwais was talking about, which is really, how can we bring long COVID patients together, and how can we communicate with them, and how can we establish a means whereby, the people of Colorado who have long COVID know exactly where to go for information and what's going on with long COVID. This doesn't exist. So we're left with email, and we're left with certain websites, but hopefully I think as people's efforts start to bear fruit, that people with long COVID in Colorado will be more connected, and they'll know exactly what's going on. Yeah.
And I believe on Zoom, there is an audio call-in number. It's listed in there. So people have been able to call in, that at least some of the people I work with that aren't as technologically able, or they don't have the Wi-Fi. So it's just another option. Perhaps that's in the email too, or maybe it's highlighted. I don't know.
Question or comment about helping folks find out about it. I did get a notice from UC Health. I'm part of the Energize Recover trial. But I'm also at National Jewish. I didn't receive anything from them. So to the extent that you are able to talk with the other clinics about pushing out information on events like this, I know that it would be really beneficial to a lot of patients. Thank you.
Sorry to ask a second question, but how long is the typical wait to try to find and get into a doctor that truly does understand long COVID? Is the wait really long?
I work virtually with the long COVID team at Denver Metro Campus, and to get to the two main medical providers, Dr. Sarah Jolly and Dr. Liz Nugent, who's a PA, it takes a while, but they have started to streamline where there's long COVID screening days. One of the OTs on our clinic or one of the PTs sometimes is the first entry point. We do have a clinical nurse navigator, Mark Brownlow, that helps with that. It does take a while because it's a full clinic, but trying to get creative with that, or trying to, sometimes people haven't even met with Sarah Jolly, Dr. Jolly, but she's been able to say, okay, here's some resources, back to Dr. Light's point of how do we help you get feeling better? So sometimes I'm the speech therapist and I'm the first person from our team that someone's seen. And I hear commonly, unfortunately, people, when they get to that point, have seen a lot of people who have called it a psychological or said, get over it, or it's not true. And and continuing to try to help people shift away from that because it's very real and true. And there are a lot of us, but I didn't answer exactly how long, but usually we can get in with somebody, but it takes a little while to get the full package of medical provider and referrals.
I think we have lots of availability in our clinics, so we can usually do that pretty quickly, like probably within 6 weeks. But and don't quote me on that, but I think that should be a reasonable expectation. The other thing I guess I would mention though is that Sarah Jolly and others have worked really hard on trying to connect with primary care doctors because I think I don't love the idea of long COVID patients waiting 6 months to be seen because I think there are some simple things that could be tried in the meantime, and time is money. So if you can start trying some safe, things that have a reasonable chance of helping and at least getting through a couple of those therapies before your time comes up to be seen in a multidisciplinary clinic, I think that's super important. So not only is that about educating primary care doctors, but they're working pretty hard on an e-consult system where primary care doctors can message some of the doctors at these long COVID clinics and just get some advice like, hey, does this sound reasonable for long COVID? And based on the symptoms, what are some things that we can start working on now while we wait? And I think that is really going to hopefully speed things up for people and bear some fruit. I think between me and Sarah, she said we agreed to switch off on the e-consults, and I think she's only gotten one. So we have a lot of, we got to get the word out and start having primary care doctors know what's available to them. Because I think it would be nice. I think a lot of primary care doctors might not take the stance of, well, first of all, a lot of them know about long COVID. I think and they want to help, they just don't know what to do. I think the providers that will frankly say, like, I don't believe in long COVID. I want to believe that those are few and far between, but if you had some recourse, like you're a primary care doctor who wants to help long COVID patients, starts to realize that a fair number of your patients already have long COVID, you just want to have something to offer them. And I'm hoping that e-consult and a few things that can be tried before these wait times to a multidisciplinary clinic, I think that's a really good path forward.
So my schedule is waiting for I don't even think I'm scheduled with you right now, but, so are you saying I should go back to my primary care? I'm sorry, did I miss something?
No, the comment was for people who have no access to long COVID care. Where should they start? And their primary care doctor, if they didn't know what to do and they wanted some more advice, could message and put in a consult so that things could get started. Yeah.
We don't.
I'd like to thank Sally and Artworks and all of you for being here. And my sister has long COVID and drastically has changed her life. Mom with 2 kids and was a managing partner at an attorney, can't work. But UC Health has been very helpful to her, and it took many years to get in to the clinic in Denver, over 2, but great help now. Thank you.
Just because we're all sitting here and the access to information was mentioned, since we're here, and you're a different pool of people than I might capture otherwise. I am one of the artists that's in the show. My project is this, what was referred to as a blank calendar. Hopefully it'll be filled in. It's called Stitching the Situation. I have a grant that I'm going to be organizing a somewhat similar show about long COVID, folks who are living with long COVID in Colorado or who have had it, don't have to necessarily have it currently. or caregivers, providers, etc. And that show is going to be at the end of the year, November, December in Denver. And so I am currently seeking people to share their stories and help get input into what would be helpful within the show as it's being formed, because as I don't personally have long COVID. I have other stuff medically, but I don't want to drive the narrative. I want to be a provider of a place, of a forum for other people to share their stories. And I do plan on having something similar to the way I think it was CU Anschutz, the public health department, did their hearsay show with research on cannabis, to have a blend of creativity and information. So there will be some form of medical panels and information as part of that show towards the end of the year as well. So I have cards, and I think I have some flyers here too. So
What's your email?
oh, the website is stitchingthesituation.org. I'll type it in.
Anybody else? Okay, I think we can conclude, yeah? Okay, thank you for joining us, and please enjoy the show, read the stories. The docs will be here for a little bit longer. I hope to have some conversation. And the information, hopefully the Zoom recorded. If it did, we'll be publishing it so that everyone can get the information again.
I just want to thank everybody who participated. I forgot to thank my husband, who's wonderfully working all the high-tech stuff, the computer, the Zoom, and all the people who drove up on their Sundays off to volunteer. And I hope this was helpful for everybody. And don't forget, if you're interested in that one-day retreat where you'll learn some really nice exercises about relaxing your body and whatnot, just put your name and contact information over there. And thank you for Artworks too, or to Artworks.